Yeah, good morning, everyone. Thanks so much for your kind introduction. I'm Dr. Uyen. I'm from a University Medical Center from Ho Chi Minh City. And thank you. Firstly, I want to express my gratitude for the organizing committee for letting me be a speaker for this very high profile congress. This is a very great honor for me, but at the same time, it's very big challenge for me. So I hope that I could overcome it safely. And in my part, I'm going to discuss about the management of the early stage Parkinson disease, especially in the Southeast Asian countries. And this is my disclosure. In my talks, I'm going to firstly give a rough definition of the early stage of Parkinson disease. After that, the treatment available for this stage of the disease um, and the last part, I'm going to mention some challenges of Parkinson disease management in our region. Firstly, about the definition of early stage Parkinson disease. Um, as we all know that the Parkinson disease is a neurodegenerative disease, is progress over time, and the early stage, literally, it's the earliest stage of the disease course. And during this early stage, the patient may experience one or more motor symptoms, um, but they also experience many non-motor symptoms. Some patients live with a uh, mild symptoms for many years, whereas others develop advanced stage very quickly. So the precise length of the early stage is very hard to determine. Some scientists also want to subdivide this stage into the premortal or prodromal period stage and the early clinical stage. But currently, because there is no treatment available for the premortal stage, so in the scope of this talk, I'm going to just talk about the available treatment for the early clinical stage. About the definition of this stage, as I mentioned before, because there is no consensus regarding the definition of this state, but it has been defined by time, the functional impairments, or by the treatment or the complications. Um, a set of criteria combining the time, for example, less than 5 or 2 years since diagnosis, and the functional impairment with the Hearn and Yahr stage less than or equal to 2 is widely used in many clinical trials. And many scientists also believe that the occurrence of the dyskinesia is the mark of the start of the advanced stage of the disease. So in this stage of the Parkinson disease, people usually had an excellent response to the medications, and this is also called the honeymoon of the Parkinson disease. In this slide, I want to show a very nice diagram that illustrated very common symptoms could be found in this stage. About the motor symptoms, they can have 2 or 3 symptoms of the Parkinsonism, including bradykinesia, rigidity, or tremor. But they also have a very wide range of non-motor symptoms, including REM sleep behavior, depression, constipation, and those non-motor symptoms greatly impact the quality of life of patients with Parkinson's disease even in early stage. And about the treatment for the early Parkinson's disease, this medications is already recommended and have many trials to prove its efficacy in improve the motor features in early PD. The medication available consists of 4 different drug class. Firstly, the levodopa dopamine agonist, levodopa enhancing agents, more particularly the MAOP inhibitors and other non-dopaminergic agents. Firstly, I want to mention the levodopa. And we all know that this is the most powerful and well-tolerated anti-Parkinsonian agents. Even after 80 years after its introduction, levodopa is still the most powerful and most effective drug for treatment for Parkinson's disease. It can effectively reduce both the morbidity and mortality. There are three different formulations accepted for treatment in this state of Parkinson's disease. Firstly, and also the mostly used is the standard formulation. It has a time to peak is around 15 to 30 minutes, and the half-life is around 90 minutes. And this is because of the pharmacokinetics of the levodopa. It needs to be used with an anticoagulants, including pancreasis or carbidopa. And this kind of drug is used widely in many PD patients. The second formulation is control release formulation, but because of the delay onset of the action, or even the daily or even the dose failure of this formulation, the use of this formulation is already limited. As far as I'm concerned, the Cinemat CRs already have been stopped to be produced. So this formulation of control release is the use of it is quite limited. And the third previously, many people believe that regarding the levodopa response in patients, mainly just the bradykinesia and the rigidity responded well with levodopa. But according to a very new trial released in 2022, in patients with early Parkinson's disease, levodopa could improve about three cardinal symptoms of Parkinson's disease, including bradykinesia, rigidity, and tremor, to be the same order of magnitude. So it's a very powerful and effective drugs to treat the motor symptoms of patients in early stage of Parkinson's disease. And the third formulation of levodopa, it is called the extended release formulation of levodopa. It is a form of capsule filled with microbits of carbidopa and levodopa dissolving at different rates. The brand name of this formulation is called Ritari, and this Ritari capsule contains a combination of both extended and immediate release form with about 30% of immediate release. And this in this form, the absorption and the action of this kind of formulation of levodopa is more stable and predictable. So it's also proved to be effective to treat patients in the early stage Parkinson's disease. Another another kind of medication also effective in management the motor features of patients in early stage Parkinson's disease is direct dopamine agonist. This is a directly stimulated dopamine receptor, and most of the available direct dopamine agonist is targeting the D2 dopamine receptor. It is effective both at the monotherapy or at the adjuvant therapy when it used with the levodopa. And actually, there is no compare efficacy studies show the difference in efficacy between different kinds of dopamine agonists. There are four different types of dopamine agonists are proved to be effective and recommended to use in early stage Parkinson's disease, including bromipexole, robineurone, beribedil, and rotigotine. The first three kinds are oral medication, and the last one is a transdermal patch. And the third types of medication could be used in a patient with early stage Parkinson's disease is MOAB inhibitors. Naturally, MOB are in charge of breaking down dopamine, and MOAB inhibitors in charge of inhibit the dopamine degradation, also enhance the densities of dopamine in the synaptic clefts. And there are three kinds of MOAB inhibitor are accepted to be used in patients with early stage Parkinson's disease, including selegiline, zonisamide, and rasagiline. To be more precise, the selegiline is only accepted as a monotherapy, when zonisamide is only accepted as adjunct therapy, when the rasagiline is accepted for both kinds of use. And some other medication also regarded as the possibly useful for using in early stage Parkinson's disease, including amantadine and antimuscarinics. But these kinds of drugs, the efficacy of these kinds of drugs is quite mild, and they also have very many side effects. So those kind of drugs needs to be used with a very caution. And I have also listed some of medications available for treatment for patients in early stage Parkinson's disease. Now, how we can make a choice between those kinds of drugs? Firstly, I want to compare about the efficacy between those medications. The levodopa is widely recognized as superior to most dopamine agonists in alleviating PD motor symptoms. And in many cohort trials, we also noticed that levodopa must almost inevitably be added to dopamine agonists to keep the control of Parkinsonism after a few years of treatment. In many head-to-head direct compare between the efficacy of levodopa and dopamine agonist, the levodopa is always superior to the latter kinds of drugs, as measured by the UPDRS motor score decrease. And also the superior effectiveness of levodopa is also illustrated in very realistic trial. In this long-term long-term effectiveness of the dopamine agonist and MOAB inhibitors are compared with the levodopa as an initial treatment for Parkinson's disease. And after about 7 years of observation, very small but persistent benefits are shown when treatment is initiated with levodopa compared to levodopa-sparing therapy. And how about the side effects of different kinds of medications? The levodopa is also better tolerated compared to other kinds of drugs. The frequency of patients stopping the treatment with treated drugs because of the side effect is extremely low in levodopa, just about 7% compared to other kinds of drugs, about 50% for dopamine agonists, and about 72% for MOAB. And another review of Cochrane's on the database of drugs also illustrated the dopaminergic complication is more common with the dopamine agonist compared to the levodopa. Those complications include edema, somnolence, constipation, dizziness, hallucination, and nausea, as you could see in this chart. And a very severe side effects of the dopamine agonist is the impulse control disorder. As you may know that the impulse control disorder is pathological behavioral disorder include pathological gambling, compulsive shopping or eating, and hypersexuality. And these kinds of side effects have very strong association with the use of dopamine agonists. The 5-year cumulative incidence of the ICDs in patients using dopamine agonists could be about 50% compared to in patients without using dopamine agonists, it's just around 14%. And ICD was strongly associated with dopamine agonist use with dose effects, the relationship. Higher doses of the therapies and longer treatment periods make people more likely to develop ICDs. And ICDs progressively resolve after dopamine agonist discontinuation. But how about the motor complication? The motor complication is longer believed that it's associated with the use of levodopa. Dyskinesia, dystonia, or motor fluctuation is significantly higher in the patient using levodopa, and it's illustrated in many trials compare the use of levodopa and dopamine agonists as a monotherapy. And in this trial, in the realistic trial I have mentioned before, the risk, however, when we observe the patient for a very long time, more than 5 years, around 7 years in this trial, the risk of developing dyskinesia in both levodopa and levodopa sparing groups is pretty the same. It's slightly higher in the levodopa using group, but it could not reach the it's quite higher, but it's not reached the significant level. And on questions raised about the use of levodopa is that does early treatment with levodopa really increase the motor complication? It's really the levodopa complications are not the a part of the disease progression. And a very well-known trial compared this. In this trial, there are two groups of patients, Italian one and Ghanaian groups. When the Italian group received the levodopa as soon as the diagnosis is made, the Ghanaian groups had a delay in using about 5 years after the diagnosis. But as you can see, after about 6 years, the time they started to have the motor complication is not different. And regression analysis in this study confirmed that the motor complication were associated with the disease duration, not the levodopa daily dose, and the levodopa daily dose, but not with the duration of the levodopa therapy. So it means that delaying the levodopa has no protective effect on the development of motor fluctuations and dyskinesia. And a very new trial has just been released 3 years ago, and it's a very famous trial. In this multi-center double-blind study targeting the early PD patients, patients are divided into the early and the late group. In early group, the patients are put under levodopa and carbidopa started at as soon as the diagnosis are made, and when in the delay group, the levodopa and carbidopa started after 40 weeks, and the investigation is carried out at the end of 80 weeks after that, and the primary outcomes show that no significant motoric difference between two groups, and the secondary outcomes confirm that there is no significant difference in fluctuation and dyskinesia. Because the major aim of this study is to investigate the modifying disease effects of the levodopa. So this the primary outcome of this study is about the difference, motoric difference between two groups. But I want to pay more focus on the secondary outcome. It also shows that there's no significant differences in motor complication between two kinds of treatment. So it means that it also confirmed that delaying the levodopa does not reduce the motor complications. So to compare between the levodopa and dopamine agonist, the levodopa is apparently superior motor effects. It have in the short term effects, it had a higher frequency of fluctuation and dyskinesia and the earlier occurrence of dyskinesia. But in long-term trial, it showed that the frequency of fluctuation and dyskinesia in these kinds of drugs are quite similar. And about the side effects, why the levodopa is associated with less side effects and better tolerated, and dopamine agonist is associated with many side effects, especially the ICDs, very severe side effects. And in this kind of drug, there's also a higher rate of drug stopping because of the adverse effects of the medications. So we have also many kinds of available medication to choose from, and I also show the comparison in terms of the efficacy and the side effects of those kinds of medication. So how can we optimize the treatment of early stage of Parkinson's disease? Based on many recommendations of the ASNA2023 guidelines of dopaminergic therapy and motor symptoms in early Parkinson's disease, and another guideline of sorry for my typo, another guideline of NICE in 2017, I composed in this diagram. And firstly, at the beginning of the therapy, we should consult the patients with early stage Parkinson's disease on the benefits and the risks of available initial therapies, including levodopa, dopamine agonists, and MOAB inhibitors. And if the symptom is minimal or mild, we could try using MOAB inhibitors as the monotherapy and the initial therapy. If it had a suboptimal effects, if it could not effectively reduce the motor symptoms, we could consider change to other kinds of drugs. And if the patient with a significant motor symptom and the patient had a younger than 60 years old, and we think that they have a higher risk of dyskinesia, we should consider dopamine agonists at the initial therapy. And the others, patients with a significant motor symptom but older than 70 years old and with other histories of ICDs or cognitive impairment or excessive daytime sleepiness, hallucination, we should consider using levodopa as the first monotherapy. But if we reach when we use those kinds of drugs as the monotherapy, but we could not receive the optimal effects of the kinds of drugs, we should consider combine those kinds of drugs. Because if we accelerate the dose of the levodopa is too high, higher than 600 milligram, it associated with a higher rate of occurrence of dyskinesia. But I also remind you that the patients with older than 60 years old should not be prescribed the dopamine agonist at first. So besides the pharmacological treatments, we also need to consider the non-pharmacological treatments for these patients in early stage of Parkinson's disease. And physiotherapy and physical activity and occupational therapy are recommended to be used in this stage of the disease course, as stated in the NICE guidelines. And also the speech and language therapy is also important. There is even a guidelines for the physical therapy could be used for patients with Parkinson's disease. And the long-term effects of regular physical activities and exercise is also illustrated in a clinical trial. In this trial, the groups of authors concluded that the maintenance of a high regular physical therapy could robustly associated with better clinical course of Parkinson's disease, and the effects of each type of physical therapy is quite different. And as I mentioned before, in early stage of Parkinson's disease, the patient is not only have the motor symptoms but also the non-motor symptoms. Here are some common symptoms could be found in patients in early stage. It including some sleep disturbances, GI symptom, mood and infection, connection, and pain also. But many scientists believe that the dopaminergic treatment also have effects on the non-motor symptom, because of most of the patients in the early stage of Parkinson's disease, they may have the non-motor symptoms, but those symptoms might be very mild and don't need to be treated by another kind of drug. So even just the use of dopaminergic treatment could also improve the non-motor symptoms of patients in this stage. It could be easily exemplified in the case of pramipexole use. Pramipexole could effectively improve the patients with the depressive symptoms. And here are some recommended treatments for patients with depression and depressive symptoms, and also other kinds of non-motor symptoms. It is included in the very quite new guidelines of the MDS. At the last part of my talk, I'm going to mention some challenges of Parkinson's disease management in Southeast Asia. As you may know, there's going to be a very thorough talk about the treatment of Parkinson's disease in our region tomorrow in a plenary session by Dr. Tai. So now I'm going to just briefly mention some of the challenges in our region. I'm going to cite a very nice review of our expert in our regions. Some of our challenges which we have to face when we treated patients in our region is firstly the knowledge gaps of Parkinson's disease, and the second one, a very big problem, is the availabilities and accessibilities of PD treatments. Regarding about the knowledge gaps, the misconception of PD was attributed to other non-medical causes is very common in patients, and therefore they want to seek treatment from a traditional healer by some kind of drugs or some traditional medicines instead of seek for the help from the professional health provider. And therefore the de novo patients in our country is not that early in their disease course. So I always have to consider using the early combination of levodopa and dopamine agonist at the beginning. And also there is also a significant knowledge gaps in the PD among the medical professionals, because there is not enough neurologists in our countries. Most of the PD conditions are treated by the internist or general practitioners. So the knowledge of those physicians is quite limited compared to the neurologist. And about the knowledge gaps in patients in our country, there is a nice study in Singapore. They show that a very low percentage of patients can answer correctly to the question is that the all patients with PD have to experience tremor, and they also a large percentage of patients also believe that there is a treatment that could cure Parkinson's disease. And about the available and accessibility of PD treatments, as I mentioned, there are many kinds of drugs, but there are just a few available in our countries. Take Vietnam as an example. In this study, published in 2020, 3 years ago, we have about five kinds of drugs, but now we just have 2 kinds, just levodopa and the dopamine agonist. So the availability of the medication also put both the physicians and the patients with PD at a disadvantage. So to conclude, in the early stage Parkinson's disease, levodopa dopamine agonists and MOAP inhibitors are recommended therapeutic agents, and both the motor and non-motor features should be effectively managed, and the medical management should be individualized, depends on each patient's conditions, including the symptom severity, age, cognitive function, and other comorbidities. And the patient should be also advised to participate in a tailored physical exercise, which could make them feel better. And this is the end of my talk. And thank you so much for your attention.